MRI of the wrist, the basics. So in this talk, I'll be discussing how to approach reading a wrist MRI and also what to look for in terms of pathology and common normal variants of anatomy that can be confusing for pathology. So first, we're going to discuss how to approach reading a wrist MRI. The most important thing is to use a checklist. So this checklist will include the most common structures that are routinely evaluated on every wrist MRI, and these include the bones, the joints, the triangular fibrocartilage complex, or the TFCC, ligaments, tendons, and other things such as the carpal tunnel, Guyon's canal, and masses. Here's a table that lists the different pulse sequences that are typically acquired with a wrist MRI and the imaging planes that they're acquired in, and what I find most useful when I'm evaluating each of these structures. So as you can see here, for most of the structures, the most useful pulse sequence is a fat-saturated T2-weighted or fluid-sensitive sequence, and the most common imaging plane that's used in most of these is a coronal imaging plane. So if you had one sequence and only one sequence, the coronal fat-saturated T2-weighted sequence or fluid-sensitive sequence is your most useful sequence when evaluating a wrist MRI. So let's talk about pathology. What are we looking for? And also a brief description of some of the important anatomy and the normal variants. So first we'll start with bone injuries. MRI is very good for looking at fractures as well as bone contusions. And it is good not only for looking for acute fractures, but also stress fractures, but particularly useful for looking for radiographically occult fractures. So one of the most common fractures that MRI is used for is the scaphoid fracture. It is the most common carpal fracture, accounting for 70% of all carpal fractures. It's usually a result of a fall on an outstretched hand or a Fuchs injury, and can be occult often on radiographs, and missed fractures can lead to avascular necrosis. MRI is very accurate for identifying scaphoid fractures with greater than 90% accuracy reported. Here's a case of a scaphoid fracture in a 23-year-old female who fell snowboarding 3 months before the MRI. And here you can see that there's bone marrow edema on the T1 weighted image on the left and the T2 weighted image on the right. And you can also see a low linear T1 and T2 signal line through the waist of the scaphoid consistent with the fracture line. And this is really the key way to differentiate a bone contusion from a fracture, and that is to look for this fracture line. A hook of the hamate fracture is another occult fracture that can happen in the wrist where MRI can be particularly useful. It's much less common than scaphoid fractures, only accounting for about 2 to 4% of all carpal fractures. It's more common in athletes, especially those who play sports that involve handling bats, clubs, or rackets, as it results from the handle of the bat or club striking the hypothenar eminence and fracturing the hook of the hamate. And like I said, these can be radiographically occult, and that's where MRI can be especially useful. Here's a case of a hook of the hamate fracture in a professional baseball player who injured his hand while batting and fouling off a pitch. We can see here nicely a disruption of the hook of the hamate at its base, both on the T1 weighted image on the left as well as the T2 weighted image on the right. Avascular necrosis is another important diagnosis where MRI can be very useful. MRI findings of avascular necrosis, the most specific are really low T1 weighted and low T2 weighted signal, as well as in more advanced cases looking for articular surface collapse. The most common locations for avascular necrosis include the proximal pole of the scaphoid, usually as a result of a scaphoid waist fracture, as well as AVN of the lunate, also known as Kienbach's disease, which is usually the result of ulnar negative variance or a short ulna. Here's a case of scaphoid avascular necrosis. You can see the low T1 and T2 signal in the proximal pole of the scaphoid, and you can also see a linear low T2 signal here through the waist of the scaphoid consisting of the fracture line. Here's a case of lunate AVN or Kienbach's disease. Again, we see the low T1 and T2 signal in the lunate, but in this case we also see a little bit of articular surface collapse of the lunate at its articulation with the capitate. MRI can also be very useful for evaluating the wrist joints. These include the articulation between the distal radius and ulna, also known as the distal radial ulnar joint or the drudge. The radiocarpal and ulnocarpal joints, the articulations between the distal radius and the carpal bones and the distal ulna and the carpal bones respectively, as well as the articulation between the carpal bones or the midcarpal joints. The joint disorders that we typically evaluate for most commonly are things like degenerative arthritis or degenerative joint disease, and inflammatory arthritis, as well as disorders in alignment that can cause joint disorders such as a slack wrist or ulnar impaction. In terms of a slack wrist, which is scapholunate advanced collapse, the MRI features consist of a scapholunate ligament tear, as shown here, with widening of the space between the scaphoid and lunate, and subsequent development of degenerative changes between the scaphoid and distal radius here, and proximal migration of the capitate through this widened scapholunate space. This can also be associated with a DISI deformity or a dorsal intercalated segmental instability, where you have a dorsal tilt of the lunate. So normally the lunate should be aligned with the distal radius and the capitate, but as in this case, you can see that the lunate is actually tilted dorsally relative to its normal position. Another abnormality of joint alignment that can be seen on wrist MRI is ulnar impaction, also known as ulnar abutment. And this results from a ulnar positive variance or a long ulna, as can be seen here, where the ulna is longer than the distal radial articular surface. As a result, you can have the ulna can abut the lunate, resulting in cystic changes in the ulnar aspect of the lunate or sclerosis. And when it progresses, it can result in degenerative arthritis both at the ulnocarpal joint as well as the distal radial ulnar joint, as in this case. On MRI, we see similar findings. Early in the disease, what we see is degeneration of the triangular fibrocartilage that lies in between these structures, as well as chondral loss in the distal ulna and lunate, as seen in this case with edema here in the lunate. In more advanced cases, there can be a tear of the TFC, as shown here, with development and also a tear of the lunotriquetral ligament and development of degenerative arthritis of the ulnocarpal as well as the distal radial ulnar joints. MRI can be very helpful in evaluating for disorders of the triangular fibrocartilage complex, or the TFCC. It's really the modality of choice to evaluate this structure. The TFCC consists of several components. The main component that we're going to focus on in this talk is the actual triangular fibrocartilage here, shown in blue. There are also the dorsal and volar radioulnar ligaments, which lie on either side, both dorsally and volarly, to the triangular fibrocartilage, as well as the extensor carpi ulnaris tendon sheath, the ulnar collateral ligament, and the meniscus homologue. The function of the TFCC is to absorb the ulnar-sided axial loading forces, as well as to stabilize the ulnar side of the wrist and the distal radial ulnar joint. Just a quick anatomy of the TFC, as this is important in order to be able to identify what's pathology and what's normal. The TFC, the disc itself, is a fibrocartilaginous disc that's biconcave in shape. A normal disc should be low in signal on all pulse sequences, similar to the meniscus of the knee. It has a radial-sided attachment that attaches to the distal radial articular cartilage and can be therefore high in signal and should not be mistaken as a tear. It has two ulnar-sided attachments, first to the ulnar styloid, as shown here, and another attachment to the ulnar fovea, as shown here. In between these attachments, there's a high signal area referred to as the ligamentum subcruentum, which essentially is composed of fibrovascular tissue. And again, this is a normal appearance and shouldn't be mistaken as a tear. Here's a case of a radial-sided tear of the triangular fibrocartilage. The image on the left shows the tear through where there's high signal separating the normal low signal fibers of the TFC. And this should be different from the normal where you see the high signal at the radial attachment, which is not a tear. So pay attention to the location if you're going to call a radial-sided TFC tear to make sure that you're not just calling the tear at its radial attachment where normally there should be high signal. MRI has shown to have a high accuracy for detecting TFC tears, and the radial-sided tears are less likely to heal and more likely to require surgery. The triangular fibrocartilage can also tear from its ulnar-sided attachments, and this is referred to as a peripheral TFC tear, as shown in this image on the left, where we can see there's discontinuity of those peripheral attachments to the ulnar styloid and the ulnar fovea, as we see on the normal example on the right. And again, note is made that you shouldn't call that high signal between the attachments as a tear. You really should not see those attachments at all in order to call this a tear. Now, peripheral-sided tears compared to radial-sided tears are much more difficult to diagnose, and arthrography can be helpful. The fortunate thing with these tears, however, is that these are more vascular, they're well vascularized in this area, and therefore more likely to heal. Another type of tear that's commonly seen, especially in older patients, is a degenerative tear of the triangular fibrocartilage, as seen in this case, where there's really attenuation and absence of the normal body and radial side of the TFC, as can be as seen on the normal. And this attrition of the TFC is very common in older patients and is often asymptomatic. So we need to be careful when diagnosing these and attributing them to pain, because often this may not be the source of their pain. MRI can also be very helpful to evaluate the ligaments around the wrist, and these are really composed of the intrinsic ligaments, which are primarily the scapholunate and the lunotriquetral ligaments, as well as the extrinsic ligaments, which are located both dorsal and volar aspects of the wrist. The scapholunate ligament is one of the most important ligaments that we routinely evaluate on a wrist MRI, and it's composed of three different components. It has a dorsal component, which is kind of band-like in structure and has a striated appearance. It has a central component, which is more triangular in appearance and can often normally be high in signal and shouldn't be overcalled as a tear. And it has a volar component, which is more trapezoidal in appearance. The dorsal portion of the scapholunate ligament is the most important in terms of maintaining stability of the joint, and it can be well seen also on the axial images as shown on this figure. MRI is reported to be highly accurate in detecting these tears, and MR arthrography can be helpful in diagnosing the more difficult cases. Scapholunate tears are associated with disc deformities and slack wrists, as we discussed earlier. Here's a case of a 40-year-old male with wrist pain after a fall that had a scapholunate tear seen on this arthrogram. You can see the tear here where you normally expect to see the scapholunate ligament on the coronal images. as well as a disruption of the dorsal band of the scapholunate ligament on the axial images. And you can also see the contrast extending between the scaphoid and the lunate into the mid-carpal row on this arthrogram. Lunar triquetral tears are harder to diagnose than scapholunate tears, mainly due to the smaller size of the ligament. And MR arthrography can be especially helpful in trying to diagnose these tears. Lunar triquetral tears are often associated with triangular fibrocartilage tears and can also result in instability to the wrist, resulting in a Vissi deformity or volar intercalated segmental instability, where there's now volar tilt of the lunate. Here's a case of a 24-year-old male with ulnar-sided wrist pain showing a lunar triquetral tear, and the image on the right shows the normal appearance of the lunar triquetral ligament for comparison. And on the orthographic image, we can actually see very nicely the contrast extending between the lunate and the triquetrum. MRI can also be helpful in diagnosing tendon pathology. And in the wrist, the tendons can essentially be separated into extensor tendons and flexor tendons. And the extensor tendons are in 6 unique compartments that are separated anatomically as depicted here at the level of the distal radius. An important landmark here in identifying these tendons is Lister's tubercle, which separates the second extensor compartment from the third extensor compartment. The flexor tendons, on the other hand, are located on the volar aspect of the wrist within the carpal tunnel, as shown here. There's only one flexor tendon that does not run within the carpal tunnel, and that's the flexor carpi radialis here to the radial aspect of the carpal tunnel. Tendon abnormalities essentially consist of tendinosis, which on MRI appears as a thickened tendon that's increased in signal, as shown here in the extensor carpi ulnaris within the 6th extensor compartment of the wrist. It can result in a tendon tear, here again in the extensor carpi ulnaris, where now there's fluid intensity and discontinuity of the tendon. And in the same case, you can actually see the torn, retracted tendon more proximally in the distal forearm. And lastly, you can have tenosynovitis, where the tendon itself is normal in signal and morphology, but you may have fluid or synovitis within the tendon sheath surrounding the tendon, as in this case within the carpal tunnel. De Quervain's syndrome or De Quervain's tenosynovitis is a particularly common entity that one encounters when imaging the wrist. And this results in this is secondary to an entrapment and irritation of the tendons of the first extensor compartment. This is usually a clinical diagnosis, but can be diagnosed on MRI as well. On MRI, what we look for in this case is essentially abnormalities involving the first extensor compartment that can be either result in low or high signal around the tendons, essentially tenosynovitis, as well as signal abnormality and or thickening of the tendons, in other words, tendinosis. The major nerves of the wrist should also be evaluated on every wrist MRI, and this includes the median nerve, which is located within the carpal tunnel along its radial and volar or superficial aspect, as shown here. And the most common abnormality of the median nerve is the carpal tunnel syndrome. Now, this is usually a clinical diagnosis, and in most cases, MRI is not indicated. But MRI can be helpful if there's concern for a mass causing extrinsic or intrinsic compression of the nerve, as well as in patients who've had carpal tunnel surgery and are continuing to have persistent symptoms to look for scar tissue and other abnormalities. The ulnar nerve, on the other hand, also lies within a fibroosseous tunnel referred to as Guyon's canal, which is bordered by the hypothenar muscles, the flexor retinaculum, and either the hook of the hamate or the pisiform, depending on the level. As a result of this tight space, there can be pathology associated as a result of any of the bordering structures, and the most common of which is fractures of the hook of the hamate, which can result in ulnar nerve abnormalities. Another common indication for a wrist MRI is to identify and characterize soft tissue masses around the wrist. The most common soft tissue masses one encounters in the wrist are ganglion cysts and giant cell tumors and nerve sheath tumors. Ganglion cysts are by far the most common soft tissue mass in the wrist. They have characteristic locations which you should familiarize yourself with, as this case here in the dorsal aspect of the wrist near the scapholunate interval. Giant cell tumors, on the other hand, rather than being cyst-like and high in signal, tend to be low in signal on all pulse sequences, as shown here. IV contrast can be helpful in these situations when evaluating soft tissue masses to distinguish a solid from a cystic mass. So in this brief overview of wrist MRI, I covered the approach to how to read a wrist MRI and discussed some of the common relevant anatomic variants as well as pathology that one encounters when reading these examinations. In terms of the keys to successful reading a wrist MRI, I think it's important to learn the anatomy of the wrist as well as important normal variants, and be familiar with the common disease processes that happen around the wrist so you can recognize them. Lastly, it's helpful to use a checklist to make sure that you remember to evaluate all the necessary structures. Thank you.